Good evening. I want to welcome you to the fourth edition of MedTalk. I can still remember the first one we did, which was pre-pandemic. The idea is that we mimic TED Talks, thus the name. We have distinguished faculty and now even medical students who give us talks that try to explain some of the incredible work that we're doing here at the School of Medicine in ways that will appeal to everyone, and that it's an experience and a way for us to talk to you about the important work that we do and why it matters, not just to you and not just to the School of Medicine, but to the country and really the world. We want to thank you for your support of the School of Medicine. We want to thank those of you who've joined us in person and those of you who are joining us online. All of that support is what makes so much of these great discoveries and these great faculty and these great medical students possible. So I hope you'll look forward, as I do, to 3 really great talks. But before that, I want to bring up our Dean, Jay Hess, who's going to give us some introductory remarks.
All right, well, good evening, everyone, and thank you, Dr. Carroll, for the introduction. So I'm about to begin my 10th year as Dean of the IU School of Medicine, and one of the things I recognized early in my tenure was the extremely high quality of the faculty. And over the course of a decade, of course, people retire and people sometimes move elsewhere. So we've been presented with a challenge of hiring talented new faculty to take the baton and help keep us moving forward. So tonight's lineup of speakers really offers 3 great examples of that. 2 gifted scientists and a promising young student, relatively new faces here who are going to take us to new heights. So first, Dr. Huda Salman, who joined us last fall, is leading our push into the exciting and relatively new area of immunotherapy. And specifically, she's overseeing a rapid expansion of our ability to extract immune cells from the body and re-engineer them to become cancer fighters. And as you'll see, the possibilities for treating patients is truly immense. And then secondly, Joel Green. His journey from Zimbabwe to become a member of our student body is truly remarkable, and it really reminds us of what determination and hard work can achieve. But his is also the story of someone through his life experiences has developed a genuine appreciation for what a gift good healthcare is, and he has an empathy that will serve him very well as a physician. And then finally, Dr. Rohan Dharmakumar, who joined us a year ago, brings a unique background in mathematics and physics to the study of the heart as our first director of the Krannert Cardiovascular Research Center. And in keeping with the great legacy of Krannert, his research could revolutionize the way we treat cardiac patients and save lives. Of course, we value all our faculty, those who have been with us for decades and those who are new to us, and we're constantly refreshed by the new faces in our student body. It's this mix of old and new, and the familiar and the revolutionary new people joining us from diverse backgrounds and interests who challenge us to learn from them, and that's what enables us to grow and thrive. That's the formula for a great medical school, and that's exactly what we have at the IU School of Medicine. So thank you for all that you do for our school and for joining us tonight as we listen and learn.
I realized I didn't introduce myself. So I'm Aaron Carroll. I am a professor of pediatrics, and I've been here since 2003 at the School of Medicine, and more recently, Chief Health Officer for Indiana University. But here's some of the people you're really here to see. Our first speaker tonight is Dr. Huda Salman. She joined the School of Medicine from Stony Brook University and Stony Brook Cancer Center, where she founded a hematological malignancy section, as well as the Cancer Center Adolescents and Young Adult Program. A leukemia survivor herself, Dr. Salman's clinical expertise is focused on hematological or blood malignancies and bone marrow transplantation and cellular therapy, particularly for really acute and aggressive lymphomas. Her most recent work on CAR T-cell and immunotherapy is extramurally funded by a number of organizations, and it's very well received in the medical community and holds a lot of promise for patients around the world. So, Dr. Salman.
It's an honor for me to be here tonight, and thank you, Dr. Carroll, for that generous introduction, and the audience for spending your evening with us. While I survived this relentless disease myself, I lived to see many people that I care about, family members, classmates, friends, and many of my patients prematurely pass because of cancer. From a grandfather who died with osteosarcoma to friends who died of acute leukes and breast cancer, and a classmate who was a genius medical student who died of brain tumor at a very early age, and now my patients. And early on in my career, when I was researching cancer and cancer cells, I realized that the cure of cancer is not really by adding more drugs, and that there is a need for innovative approaches to be able to prolong the survival or even cure this disease. And I'm going to tell you why it's not with drugs or adding more drugs that we cure cancer. So traditionally speaking, we used to treat, or we still are sometimes treating cancer with, if it is limited, with surgery and radiation therapy. And then if it is disseminated or metastasized, we treat it with chemotherapy. And all of those, they come with limitations and peculiar adverse events to each of them. And most recently, we also started identifying cancer markers or biomarkers that are expressed by cancer cells, and we tried to target those. And there are many, many of those, from targeting, from targeting the tumor DNA and the mutation, to the way that it uses other tissues, autophagy, to feed itself, to how it proliferates, and all of these other mechanisms that we use to target tumor cells. But what we saw is that most of these methodologies, including the traditional and the most new, is that all of those, they pour into drug resistance. And that's why the tumors come back. And again, I'm going to show you why that is. It's because of what we call tumor heterogeneity. So if we take a tumor that is getting established or growing, it's composed of millions of cells, and although the majority of these cells are very similar, there are minor differences between them that makes them susceptible or resistant to one medication versus another. So as we treat these tumors, we realize that some of these cells, with the minor differences that they have, they respond to the modality of treatment that we use, but then we either can add some of them are resistant, and some resistance we create by using those medications that I went over. And we end up with the tumor either not going away or coming back and goes away for a short period of time. Because of this, again, we try all the time to come up with more innovative ways of treating this tumor. And tonight here, I'm going to talk to you about immunotherapy, how it works, and what's the outcome, and how did it affect patients' outcome and everything. So we look at this here, a T cell. It's a representative of the immune system. And this T cell have coexisted for a long time with normal cells, because this normal cell carry a red signal on its surface that tells the immune cell, don't eat me. I am your friend. I'm from this body. Don't come near me. When cells are changed by either an infection or even a trauma, inflammation, or by cancer, because of the mutations and the genetic changes that happen in there, these cells they have initially a signal that is a green light, and it gives the T cell a green light to eat it or kill it. And that's the mechanism by which the immune system kills cancer cells and kill any other cell that is not useful to the body as of that time. And those two, the red and the green signals, they are called immune checkpoints. And because cancer cells are very clever, they always try to evade the immune system that we have. And the way they do this is by increasing their mutations and changing their morphology to try to trick this T cell that I am familiar. I am like the normal cells. And that will lead to the exhaustion of the T cell because it keeps trying to kill those cells, but then now the cell is more close to the normal cells, and that doesn't happen. And so scientists over the year thought about blocking these red signals and make this mechanism whereby the tumor cell tolerizes the T cells to it not valid any longer. And two of the most famous scientists in this are James Allison and Tasuku Honjo, who in 1990s discovered something called checkpoints inhibitors to try to stop this resistance mechanism. And those drugs that would stop this are immunotherapy. They are monoclonal antibodies that will block that interaction between the T cell and the tumor cell, making it more amenable to be killed by the immune system. And for that, the FDA approved this modality of treatment, and we have many of those now approved by the FDA. And the two scientists, they won the Nobel Prize for this very big discovery in cancer treatment. And then the other mechanism, which is, like I said, one is a green light and one is a red light. Now, the green light is, we can enhance that. We can make the T cell more resistant to this trickery that the cancer is trying to impose on it. And one way of doing this is by enhancing those T cells. And the way we enhance the T cells is by introducing a genetic material into it called chimeric antigen receptor piece of DNA that will we introduce through a disabled virus into the T cell. And this piece of genetic material will go to the DNA of the T cells, and then it will be expressed as monoclonal antibodies, similar to the ones that the other two scientists created for checkpoints. And this T cell will become much more equipped and empowered to go ahead and fight cancer again, enhancing that green signal that we spoke about, and then attaches itself to cancer cells and boom, kill it. So that's the way this particular modality treat cancers. There are now many, many, many ways that we can enhance and empower the immune system to do this job by making it stronger to attack cancer cells. One of them is the CAR T cells I spoke about. One of them is similar to the CAR T cells called fusion proteins, and of course the monoclonal antibody, which is one of the older modalities in immunotherapy. And then we have tumor vaccines, whereby we take some cells and expose them to the tumor antigens or proteins and then make them more empowered. And then we have oncolytic viruses that we can use, cytokines to stimulate the immune system, and natural killers is part of, like the T cell, it's another part of the immune system. We can take them out, expand them, make them stronger, and put them back in the patient, and so on and so forth. And this field is very active right now in research, in production of treatments and drugs all over the world, and mainly here in the United States. They do have side effects, and the major side effect, unlike chemotherapy, where they, for example, suppress the immune system, they cause organ dysfunction, they cause hair loss, they cause resistance, and all of these things, as I spoke about. The major side effect of CAR T cells or immunotherapy is overactivation of the immune system. It's in science called cytokine release syndrome, if you guys have heard of that anytime. So because these T cells go into the body and they are very strong, they produce a protein or proteins called cytokines that they fuel themselves by. And at that point, they are so powerful that they might also attack the normal cells together with the cancer cells, but by no means as much as they attack cancer cells. And that is one of the major side effects that we're trying to modify and adjust and make it less without affecting their efficacy towards killing tumors. What may be the future of this field? Lots of things are happening, such as evaluating of these modalities early in disease, because in research, first we use them in advanced disease status, any medication, including immunotherapy, and then take them into the upfront. Although some of the diseases, they have them upfront now, but not all of them. So that field is open for research. Optimizing biomarkers and changing their schedule. Biomarkers meaning finding more targets that the T cell can attack, and then playing around with their schedule to decrease the side effects while keeping them effective. Identifying new targets, evaluating them in combination with chemotherapy in cases of more aggressive tumors that we don't expect the immune system, even with the empowerment of immunotherapy, to be able to fight cancers. And then evaluating them across cancer types, because for now it's only in a handful type of cancers that we use immunotherapies. And a few years ago, I did not think that using the immune system and empowering it to this extent is possible. But now, with the promise of immunotherapy, I know that we are on the right path. And thank you very much for listening to me.
Thank you. Thank you so much. Our next speaker is Joel Green. Joel is a second-year student at the Indiana University School of Medicine. He's a first-generation college student and spent most of his life in Harare, Zimbabwe. He was raised by a single mother with limited means who was unable to afford adequate health care and schooling at times, but he dreamed of being able to go to school and to obtain an education. When he was 15, his mom died, leaving him orphaned, but in 2015, he immigrated to Indiana to live with extended family, where he's been able to realize his dreams of getting an education, including now his pursuit of a medical degree. I am very much looking forward, as I'm sure all of you are, to hearing his story. Joel.
Thank you all for coming, and thank you for that amazing introduction. So good evening. As you all heard, my name is Joel Green, and I'm very excited to be speaking with you all today. I would like to begin by stating how incredibly honored and humbled I am to have been selected as a recipient of the Steinmetz Family Scholarship. This is arguably one of the most amazing gifts that I have ever received, as it allows me to take a step closer to achieving what I believe is my life's calling. As such, I am honored. I'm incredibly humbled, as these opportunities, both being a medical student and getting a scholarship, just do not happen to people like me. And to give you a better understanding of why this gift is so meaningful to me, please allow me to share a very truncated version of my story. Like an elaborate mosaic, who we are is a summation of multiple intricate experiences. And for me, the richness of my own experience is only clarified now as I look back on this journey through a lens of newfound appreciation. So I grew up in the slums of Harare, in a country battling economic instability brought about at the hands of a ruthless dictator. Through this, I've endured many challenges, some very apparent, like hunger and poverty, but others not as clear, but of equal significance. And as I look back at my past, there's one experience that is etched in my mind. And it is this experience that truly changed the trajectory of my life. So the rails rattled as the mortuary rack slid out the cooler, and a cold mist spread across my face. As the shroud was undraped from over her face, almost instantaneously, tears began to roll down my cheeks. I was living my worst nightmare. Right before my eyes lay my mother. I never knew that only 2 nights earlier, when she told me that she loved me, would be the last time I would hear her voice. I was barely a teenager at the time and came from an impoverished single-parent home. While growing up, I had essentially no exposure to medicine. However, after Mom died, while tragic, that revealed the need for and encouraged me to pursue this path. Despite the astronomical obstacles blocking me from achieving this goal, I remained resilient and persevered. So this drive stems primarily from those heartbreaking emotions I felt as those tears rolled down my face. Like many impoverished people living in Zimbabwe, my mom's death could have been prevented if she had access to adequate healthcare services. However, for us, that was not an option. You see, my mom suffered from a severe form of uterine fibroids for many years. She constantly tried to seek medical attention, but she was turned away as we could not afford the care that she needed. Now, sadly, over the years, the disease progressively worsened to a point where she was bleeding constantly for months without end, and eventually her body could not bear this suffering and she passed away. And it was in that moment, as I stood there with my teary eyes staring at Mom, that I realized the need to be there for people like her and to do everything possible to spare others from the heartache that I felt. Through all this sadness, I found my why to pursue medicine, but the how proved even more challenging. You see, after Mom's passing, I was orphaned, and I had nowhere to live. I was bouncing from place to place without any concrete stability for a few years. But thankfully, during this difficult time, I moved to the US to live with extended family. Now, even though the transition to life in the US was difficult, once I was here, I was fortunate to attend an accelerated high school program at one of the top schools in northern Indiana. This was challenging with my lacking formal education, as Mom could not afford to send me to school. Going to school has actually always been a dream for me. In fact, as a child, I would walk to the far edge of our community. There was a school there, and I would sit bare feet, because we didn't have shoes. I would sit bare feet atop a rock, and I would watch as other kids walked into the school, very neatly dressed, backpacks on. In Africa, most schools wear uniforms, so I always wanted to wear a uniform. But unfortunately, as I sat there, I would wait and hope that someone would come say, "Hey, buddy, come on, let's go to school." But unfortunately, that never happened. However, here I was, many years later, having the opportunity to go to school. And although I was excited to go to school, I was so nervous and had so many fears. I did not know whether I was able to understand anything. Keep in mind that up to this point, I had essentially no formal education. Now, fortunately, my mother did teach me how to read and write at an early age. And in fact, when I was living, in Africa, in the slums, I would always, if I had a chance to read something, this sometimes allowed me to expand my mind and dream beyond the barriers that were right in my face. So ultimately, I think it was a combination of, being able to read and write and a ton of hard work that made me, or at least afforded me the chance to graduate as one of the valedictorians from this high school program. Now, navigating high school as an undocumented student was not particularly challenging, as everyone had similar experiences. However, when I went to college in undergrad, my immigration status was a terrible burden. And it reared its ugly head at every turn and prevented me from having the same opportunities as my peers. Specifically, it prevented me from taking advantage of great opportunities like applying for research scholarships, being a TA in class, or even getting work-related clinical experience, as all these things require you to have some form of legal status. Now, while going through this, the real difficulty was feeling like I was thriving in school because I was doing really well, but I always had this constant feeling like my goal could not be achieved. I was plagued by a chronic fear of deportation, a feeling like all those endless nights that I had spent studying could just suddenly be taken away from me. Now, fortunately, I'm no longer undocumented, and although that chapter is over, going through that anxiety and uncertainty of life taught me to be empathetic and compassionate with others. The reality is that everyone goes through a difficult moment at some point in their lives. And it is in these moments that we need someone there to help us. That is what medicine means to me. Doctors are there to catch their patients when they're at their most vulnerable moments and they're needed the most. Ultimately, as I look back on this journey, I appreciate all the struggles I faced, as it was reflections on those difficult moments that showed me what I should do with my life. There are many metaphorical references that have stemmed from my experiences growing up, and I've used these metaphors throughout my life to highlight certain things. As I sat atop that rock at the edge of the school, day after day, waiting and longing for someone to come and give me an opportunity, no one came. However, now someone has shown up. Through your extraordinary generosity, you are that someone. You have afforded that little guy who would cry to go to school both the opportunity to realize his wildest dreams and hopefully make his mother proud. And for this, I'm incredibly thankful. As I continue this extraordinary journey, although I'm not certain what the next chapter will bring as far as, what I choose to do specialty training-wise, I know if I remain true to myself, I will end up exactly where I need to be, or rather where I can have the greatest impact. Thank you for listening to my story.
Wow. I think we've met who's going to be hosting this in a couple of years, so I'm going to be out of a job. That was fantastic. Our next speaker is Dr. Rohan Dharmakumar. He's widely renowned for his groundbreaking research that spans the physical and biological sciences, engineering and medicine, and translational imaging science. In 2021, he was named the inaugural director of the Krannert Cardiovascular Research Center, a newly established part of the Cardiovascular Institute. He was recruited to the school from Cedars-Sinai Medical Center in Los Angeles, where he served as Associate Director of Biomedical Imaging Research. His latest research is focusing on understanding the damage to the heart that continue even after arterial blockages are reopened and ways to prevent that from happening. Dr. Rohan Dharmakumar, we'll look forward to your talk as well.
Thank you, Dr. Carroll. Really had a great time listening to both of you. I don't know if I can keep up with the last speaker, Joel, but I'm going to try to tell you a story that we've been working on for a very long time. And really, thank you all for being here. Really an honor to be talking about this work that we've been doing for what it feels like now, a couple of decades. So we work on a number of different problems in the heart at the Krannert Cardiovascular Research Center. One of the areas that we're working on in my program, particularly around ischemic heart disease, is this whole idea of heart attacks. And all of us are very familiar with heart attacks. So you also know it is the leading cause of death in the US. And we have about 1 million heart attacks per year. So if my calculations are correct, by the time you take 5 breaths, we'll have a heart attack. That's what's going on. So it's really a big problem. So, 50s, 60s, 70s, even part of 80s, really saw people who have a heart attack just die. Really just not too much there. But then there was a very big revolutionary idea that came out, well, let's open up that artery that is getting blocked, which we call the coronary artery, the artery that supplies blood to the heart. And that led to what we use now, stents, right? So you have somebody comes into the hospital with a heart attack, you put in a stent, you reestablish blood flow. That has been a massive hit in terms of how many people we can actually survive from a heart attack. But there's also problems. So that is the standard of care right now in terms of opening up the artery. But there's been something else happening. So even though we're able to save people from immediate death, unfortunately, these people are dying a lot faster than they would otherwise, unless something is going on that's causing them to die a lot faster. So we are seeing about chronic heart failure in about 2 million patients that are living in the US. And about 250,000 people are added to this number each year. And in a number of patients, 50% of these patients are dying within 5 years. And this is really a big problem. It's 300,000 patients that are actually dying due to congestive heart, chronic heart failure. So what's going on? We've opened up the artery, and all of a sudden, within a short period of time, there's a large fraction of people that are dying of chronic heart failure. So all the things that we've done so far really does not address that problem. There are therapies that are there just to keep people alive for a slightly longer period of time, but this is a daunting problem that is becoming an epidemic in the country. So what are the major contributors to essentially people developing heart failure? What do we know about it? So over the past 30, 40 years, what we've learned is that if you had a very large heart attack, in other words, a lot of the heart muscle is dead, then you're in trouble. Or if the heart, essentially a heart attack is a real big wound in the heart, right? So it needs to heal. If there's a slow healing, that's also not very good, right? So these are both factors that we do know. So the first one, the infarct size, the size of the infarct, that's why the American Heart Association really promoted this concept that time is muscle. So in other words, if you're having a chest pain, get to the hospital quickly so we can put in a stent and open up that artery as quickly as possible and survive or salvage as much of the heart muscle as possible. The slow healing part is a little bit of a mystery. We don't really know why that happens, why some people's hearts heal faster than others. Okay, so in our program, we're really trying to advance a concept called time is vessel. Okay, so American Heart Association has the slogan, time is muscle. We're talking about time is vessel. So what are we really talking about? When you look at hemorrhage, we know hemorrhage has an ugly face when it happens in the brain. When you have a stroke and it's hemorrhagic in nature, that is really devastating. I mean, death is almost imminent in these cases. But it's a very similar thing that's happening in the heart. And what happens is very different between the heart and the brain. It is a condition that is actually imposed in some way by reperfusion. So I'm not trying to say that we shouldn't reperfuse people, but there's something happening fundamentally different in about 50% of the patients. Because we are seeing after revascularization, in other words, putting in a stent, half the people are having these bleeds. So you might say, well, yeah, it must have been going on for decades. How do you know this now? Well, the major reason we know about that now is because we have imaging technologies that are non-invasive, like magnetic resonance imaging, that allows us to actually identify those patients. So you open up the artery. There are some people that are going to have their arteries actually burst. And blood, now where it's supposed to be inside the vascular bed, is going to be outside. Okay. So what does that mean? Well, there's something very good and bad about the red blood cells that carry the oxygen in the blood. They're great when they're inside the vascular bed. When they get out of the vascular bed because the vessel broke, for instance, then they start to cause a lot of other problems, because one of the key components of protein in the red blood cell that carries oxygen is called heme, and at the center of heme is iron. These all start to kind of break down, right? Because the red blood cells is no longer in an environment where it can be supported, so it starts to break down. And what we now know in a paper that we published this year is that this heme can also kill heart muscle cells. So in other words, what we found is that it can actually increase the infarct size by a factor of 2. It's alarming, right? Because we are opening up the vessel thinking that we're doing great things, but this opening up the vessel is actually causing more damage in some of the patients. So we're getting a very large infarct size. So keep that as a thought, because it's tied to that infarct size story I told you as one of the factors. The second is that this story is not over, is that once it starts to break down and it causes the heart muscles to die, that heme, iron, it doesn't really go away. And now we are learning that after 10 years of research in following patients, that this can stay well past 10 years in a person's heart. Okay. So what's going on? What happens is that this iron particles actually start to come together and form sharp crystals in the heart. And this is also a very new understanding that we developed. And these sharp crystals, what they do is they cause an inflammatory environment that is really very difficult to control. At least it's never been controlled to this point. And what that inflammation does is that it also changes that infarct territory, or that part of the muscle that is dead. See, I'm used to know, I learned when you have a heart attack, that muscle is dead. But what is surprising is that muscle is not dead. It is just completely changing as time goes on into something different. And the last of its fate, essentially, is that in cases where you have this hemorrhagic infarcts, bleeding, iron deposits, and crystallization of iron, and heavy inflammation, is that it leads to the infarct zone becoming fatty. So if it becomes fatty, imagine the heart's trying to contract, and you have a fatty tissue over here. But before that, there was fibrosis, right? So it's like a scar. So the heart contracts, and the blood pushes out. Now you have fat, and the heart contracts, goes like this. So the blood actually doesn't leave the heart so much. And that's what we call heart failure. Heart failure is a condition where there's not enough blood getting into the circulation. So this is a case where it is starting with an index event, initial event, that is constantly changing phase over a period of time, that is actually accelerating how the heart is remodeling and changing and leading to reduced blood flow into the circulation. Okay, so the current paradigm essentially is you have a heart attack, person comes into the hospital as soon as possible, you revascularize, put in a stent, for instance, and that would be an acute phase and the chronic phase. And there are drug therapies that are to keep them, from moving on, developing other heart attacks and things like that. But that is the current status. And what we are working on is something fundamentally different, is that it still follows the same path, but what we are saying, we're not saying don't put in a stent, don't open up the artery. I'm not saying any of that. What we're saying is there are opportunities to intervene in a very clever way, and it goes like this. And these are a number of things that we're very excited and working on. So one, we are working on drug therapies to remove this iron in the patients who are actually having this hemorrhagic infarction. Second, we're working on a fast MRI technology that you can actually image these patients and get very accurate information. Third, we are really developing a new blood test that can potentially identify hemorrhagic patients without having to rely on very expensive technology, which things like MRI, unnecessarily, because not everybody's having hemorrhagic infarction. So it would be really nice to know who's having a hemorrhagic infarction without having to rely on very expensive technology. So that's something that's very exciting here. And then we are working on drugs that can inactivate or block the activities of heme that is coming from the red blood cells that are going to damage the heart. And finally, and foremost, you can probably imagine that it would be great if you can prevent hemorrhage from the beginning. So we are very excited about developing all of these. So in summary, what I want to leave you with is that we are in a phase at the Krannert Cardiovascular Research Center of developing really innovative technologies that are going to deliver the next generation of care in the heart, in myocardial infarction or heart attack, that has not been seen in the past half a century. So this is what we're very excited about, and we think we are very, very close. And so first, the first drug to remove iron, that's actually a study that is going on in IU. It is the first in human study. It is approved by the FDA, and we are very excited to get that started. And there are lots of other advancements that are going on as well that I think are going to be what I feel and what our group feels is going to be really revolutionary in the way we would actually take care of patients in the years to come. Thank you for your attention.
Well, that was fantastic as well. And so the next stage of our program is I talk for a few seconds and delay so that your attention is fixed on me while people move these chairs over. We're going to sit down and actually ask some questions further from our three speakers. We've certainly learned quite a bit, but we also like to just go a little bit further and see if we can have a bit more discussion. So if I can invite our three presenters to join me, we will shift the camera and move over to the seats.
We're waiting for you.
So thank you again. I actually wanted to start with Dr. Salman first. First, a very easy question. I want to know who made those drawings? The ones you used. Who made the drawings? Did you make those drawings in your slides?
Not me personally. Why are you asking?
Because they were great.
No, I did not make those.
Oh, that's too bad. I mean, they were fantastic. I was just curious. Why can we not just start using immunotherapy then for all cancers? Why is it, are you focusing on, say, leukemia right now? What is preventing us from trying to do this for everything?
So many reasons. One of them is related to the cancer types themselves, and the other is related to how we develop research. So the ones that are related to the cancer type itself include how many biological markers that cancer is displaying, because some of them they have many, so we can see them, we can target them. Some of them they don't have any, and that we call low mutational burden, and they traditionally do not respond to immunotherapy very well. So that's how we select what cancer to start with first. We are up to even trying to induce these markers in tumors so we can make them amenable to more immunotherapy, because if they lack them, they don't have them, then we can also make them, we can induce them in the cancer and then hit the cancer with artificial biomarkers. That's related to the cancer itself. And the reasons that are related to how we develop research is because we first try in advanced cases, sometimes regardless of what the cell of origin or the organ of origin. And then if they are very successful, then for those patients who literally have no other choices, then we take them upfront to a second phase and a third phase of clinical trials. So that's why we can't just give them to all cancers.
Okay. Joel, I know you said that you're not sure what you'd like to do, but I don't care. I'd like to know what do you think you want to do when you finish medical school?
So I think what I want to do is I probably want to do something in surgery, and the reason is this. So over the summer, I was part of the IMPRESS program, and I learned about something called the triple threat of academic medicine. So doing research, teaching, and of course taking care of patients. But then I think that there's a fourth dimension of that is given when you are a surgeon, which is being able to donate your time in the developing world, which is something that I have seen. So this is something that I really want to include in my life's work. So that's kind of why I'm interested in surgery specifically.
So, I mean, you also described not even being able to go to school, that you're sitting on a rock and watching. So, I mean, I'm sure everyone else shares my wonder. How did you catch up? When did you catch up? I mean, you clearly not only caught up, but leapt ahead. What did you do?
So, I mean, it's an interesting question, and sometimes, because sometimes I'm oblivious to this fact, right? So sometimes, when I tell people this story, they're like, wait, what?
Yes.
You come to the US, you didn't do middle school or elementary school, how did you catch up? And I think in part it was really being able to read and write. I say that but it was something that I really did enjoy doing. But it was really difficult because even when I did end up coming to the US and trying to study for English specific, now I speak English as a first language, but I don't speak high school English.
Sure.
I did not understand any of preposition, this and that, sentence structure. So I think the fact that I was able to read and write played a huge role in that. But I mean, that's language specifically. But all the other domains, I think I was just blessed to where like I was able to utilize like some tutoring from peers as well as just like YouTube. But it was tough because imagine trying to like learn like pre-calculus in high school or even like calculus in college when like they assume you know a whole bunch of stuff and you don't know that. So I feel like I had to put in so much more time into studying and trying to figure things out. But like I say, even sometimes I don't know. Like I think I was just blessed to where maybe I got lucky enough to understand some of this.
It's just simply amazing. Wow. Dr. Dharmakumar, I had a question for you. Do we see the same kind of damage if there's bleeds with other muscle? Does heme get into other muscle, cause crystals and long-term damage, or is this just heart? Is it specific to cardiac muscle?
You're not the first person to ask that question, but I don't have a proper answer for you. What we're seeing is in the heart. Part of the reason may be, I'm not saying it doesn't happen, but the vascular bed in the heart is very different. 10%, blood volume is around 10%. So there's a lot of capillary beds. And, I don't know if anybody was looking for it. So that's the other issue, right? When you don't look for it, you don't find it. So whether that's the case or not, I'm not sure in the other organs. But I just followed the trail, right?
Yeah.
Right? So the thing is, we didn't start out with the idea, well, it could be crystals in the heart. No, it didn't happen like that. It's all somewhat serendipitous, We were doing a study actually around, 20 years ago at Northwestern. And I was doing imaging studies, sitting around, my student was imaging, and I said, what is that? It shouldn't be there. It's like, it's an artifact. So we said, okay, that's an artifact. Next subject, same thing. Okay. Now it's starting to look a little strange. So then we went and did histology, and we found out there's all these iron deposits that are there. And we had no idea that it's not supposed to happen, because the conventional wisdom around that time is, yeah, sure, hemorrhage happens and it clears out. Because the tools that we had at that time did not tell us that whole story. And we were developing these tools as well at the same time. And having access to preclinical studies and being really immersed in it really taught us a lot of new things. And it's not until, I was talking to an immunologist, I said, I think I slipped out, actually. He was talking to him. I said, it's probably iron crystals. He goes, what, crystals? Now he's like, oh, you've got to check if it's crystals, because that's a whole different story if it's crystals, right? Because we know about gout and things like this. And we checked, and one of the nice things is that we have really a large collaboration network. So we needed to prove that these were crystals, right? How do you prove they're crystals? So you need like all this fancy equipment that was not around anywhere. So we went to the national labs. And that's where we found out that you have a clear lattice structure of iron that is laced in this tissue. And so, I don't know if I answered your question, but really what it is that it's not something we started out with. It may be that it's in the other organs as well, but in the heart, certainly, in hemorrhagic infarcts, this is happening. Now, the question that you asked is very important, because I think there is an interplay between the ability of the macrophages to clear some of the debris versus being overwhelmed by it, right? So if you had maybe small levels of hemorrhage, maybe those things can be removed. But when it's a lot, I think that's the other thing. The macrophages that come in also get polarized when at a certain concentration, so into the bad kind, So I think you may see it in other organ systems, you may not, but I think in the heart, when you have large hemorrhage, that is detectable on MRI. You're definitely seeing this happen.
Dr. Salman, I was wondering if you could talk to us a bit more about CAR T-cell therapy, because we certainly hear about it in the news. I keep seeing more cancers using it. It just seems like such a big breakthrough. How does it actually happen? I mean, I wonder if you want to walk us through the mechanics of how someone gets it, because it's clearly very individualized. And when it works, does it then work forever, or is it the kind of thing where it's like a drug and then it fades?
Okay. So the promise of CAR T cells is that they are live drugs because you're giving cells to the patients. And these cells, not only cells, but they also are empowered by the gene that we put in them. And so the promise is that they will live to a certain period of time. It doesn't happen with every patient, but it happens. How do we make them? It depends on the type of the CAR T cells. Some of them are taken from the patient themselves and then engineered and put back into the patient, and some of them are donated by other patients. I myself have a trial that is FDA approved, and I treated 2 patients on it targeting T cell malignancies. And how that one works is that I take blood from patients, and then I separate the T cells, take them to the lab, and introduce that piece of DNA into them that makes them stronger. It has a co-stimulatory molecule and a monoclonal antibody that will target the tumor. And then expand them, so I get from the patient 1 million cells, and then at the end of the procedure I have many millions of cells, and then I infuse them back to the same patient. The process takes about 10 days. If they are taken from a donor, then it's somebody else, and these cells are dealt with the same way, but they have a different way of giving them and dealing with their side effects and all of that.
But when it is given and they actually work, do those cells then live forever in someone? And do they continue to work and keep cancer at bay better than other therapies? Okay. Or do they die off and then cancer?
So yes and no, and all of what you've said.
Okay.
So we know, because every patient is different and every response is different. So the oldest CAR T cell was given about 12 years ago to a kid whose name is Emily. And that was done at University of Pennsylvania. It's almost 12 years ago now, and that patient had ALL, acute lymphoblastic leukemia, the type that I had when I was a kid. There was no CAR T cell at the time. And then it was given to a similar disease, which is chronic lymphocytic leukemia, about the same period of time. A few months ago, there was this long-term follow-up on those patients. And it was found that in some of those early treated patients, they still have some of those, not all of them, which indicates the difference between a patient and next patient, that these cells are still there. They have polarized into a little bit different cells, and these cells are sitting there making themselves ready to act if they are needed. And that's what makes them live cells. In my study, for example, the patients that I treated, my endpoint in detecting these T cells was supposed to be day 28 after giving them. It's because it's a new therapy, it's not used before, we don't know anything about it, different type of cancer, so on and so forth. So what happened is we saw them on day 80. Both patients got bone marrow transplant after that because that's the way my trial works. But even at the time of the transplant, these cells were there that we had to get rid of them because now we have to make room for and the appropriate conditions for the incoming graft of the bone marrow transplant. For patients who don't, the average time for these cells from other trials that they're seen is about 8 months. And whether they continue to work or not, again, it depends on the tumor. I can't say in 100% of the time, but in a very high percentage, as in 85, 90% of the time, it continues to work. And we're trying to find out why those 10% that don't work, why is that happening, to try to go around it.
Given that the rate of success is so high, why are we not doing as much of this as we possibly could, or are we doing as much of this as we possibly could?
Because it's very, very expensive. That's number one. Even the ones that are FDA approved, each treatment costs almost $500,000. The follow-up is very intense, and so on and so forth. Producing them is extremely expensive, whether it's with me in an academic institution or even with pharmaceuticals. And so we have to work on that, either to align some more funds to doing this research or to try to cut down the price of what it takes to make these cells.
What makes it so expensive?
Probably the number of people and the teams that work on them, the lab personnel, what is required in the lab, and then what's required in storing them, making them clinical grade, and then the clinical team that would work on them, including nurses and doctors and all of that. So it really takes a village to produce these, in addition to the disposables and what we use of chemicals and viruses and all the other things that we use in the lab.
Dr. Dharmakumar, I wanted to ask you, so clearly once you have the heme deposits and the crystals, and you were talking about drugs that you could give to try to remove the heme, and I was struck by the idea that, well, those drugs I imagine would be in the blood flow, in the blood, and we don't want them getting out, we don't want bleeding. How do they get to the heme?
Sorry, you mean?
I was thinking because the whole point is that we don't want clearly leakage out of the vessel. So how is this a drug that you would give orally by IV, and how would it, or do you have to actually get it to the crystals?
So it depends on which phase of the myocardial infarction you're talking about. If you're in the acute phase, that's a different type of situation. If you're in the chronic phase, it's a totally different situation, right? So let's take the chronic situation, which that's the trial that we have started here. And in those cases, so we've already done the preclinical studies, and we know that they're getting there. They do get there because there are vascular beds that take them there. There are vascular beds that get developed in the infarct tissue. So it's not completely dead. It's actually, quote unquote, alive, not doing exactly what it was meant to do, but it's there. So those drugs are actually getting there. And in the acute phase, and this is a very perceptive question because there are ion chelators. There's lots of different ion chelators. Some of them will not get there because they're so big, right? They have to see these ion particles are actually inside macrophages.
Right.
So they have to go in intracellular. So those are some of the key things that we define through our studies, is that it has to be a ferric chelator, it has to be intracellular, and it needs to be small enough to be able to get there. So those are some of the key aspects of the drug therapy. So they're essentially tailored to the phase of the infarction. So that's how you deal with the chronic phase. In the acute phase, the iron is not in Fe3 plus state. It's in an Fe2 plus state or different state. So your chelator or whatever drugs that you're going to have to design it to meet that need. So even that understanding was not around, right? So the understanding that we've developed is that this changing chemical composition of iron over the period of the infarction, that is also different. So if you just go with any ion chelator, it's not going to fly.
Well, I could sit here and ask questions all night, but I notice we're really out of time. I want to thank all three of you for being with us tonight. I want to thank all of you in the audience for joining us, and of course for your phenomenally generous support for the School of Medicine. I'd also like to thank everyone who's been joining us on video. This has been an absolute pleasure, and I look forward to it every year. And hopefully we'll all get together next year and learn more from a whole new set of speakers. So once again, thank you to our speakers, and thanks to everyone for joining us.